I think we go to some more neutral patient here, because this one is really at the higher end. So maybe we will start with that other patient. Now, that will be more the daily life sample. We have. So what kind of symptoms do we have? We have some kind of SLI sacroiliac joint blocks on the left-hand side. You can see a bit of a dent in the waist, so which also gets reflected by the lateral deviation and then also for the surface rotation. We have a kyphosis angle of 51 degrees and 44 degrees of a lordosis. Male patient, 44 degrees is definitely at the higher end. So if we talk from 35 degrees as a maximum on male patients, so 44 is a bit much. Could be some first indication of some sacroiliac joint blockage. Who knows? Let's see. But talking from the sagittal profile, so the lordosis angle would be less than 70, still at a higher end, but we can also talk about this in a subjective way. And that's something that a kyphosis angle, for example, will never be able to give you. So the kyphosis will be measured from here to there. And everything that comes together here will be a kyphosis. It will never be able to respect this vertical alignment here. So we have a rather rigid, not smoothly shaped, integrated into the S-shape bow, but a very straight line here at the upper thoracic spine. That's something kyphosis angle will never be able to give you and to make you understand. So in the sagittal profile, or the sagittal tab, we only talked about the left-hand side now. So now we can go again for a double check here. So we have our points all at the rather correct position. So with the ITL at T12 and ICT at approximately C7, maybe a bit higher then. ICT a bit higher, just sitting on top of that straight compartment here. And well, the lordosis apex matching to the lordosis angle a bit lowered, so at L3, but still not totally out of any positioning. But talking about the cervical thoracic junction a bit higher up, then we can move to the inclination. So the inclination is nothing more than the representation of your vertebral bodies moving into flexion or extension. So that's what we connect then one segment to the other based on the surface, of course, and we can see how that inclination of a segment is adding to the surface structure. And there are some parts that are adding more to it and some that don't. Now, to make this understandable, I normally try to use that block model of the vertebrae, because this is giving me more of an abstract view on it, and we don't get distracted by any morphological information here. Now, what do we need the double S shape for in the spine profile? What does it give us? Any idea? So it could also be straight. It could also be just a straight line. So then we would just have, our head would be some kind of a lamp, and that would be the lamp post that is holding us. Why is it double S shaped? Sorry? The double S shape is there to contain the center of mass in a very narrow area. So means that if I have a straight or a straight spine. So I have a distance of my kyphotic apex to the front of my trunk that is something like this. And somewhere in between, there will be my center of mass. So there's not much way to go, so the center of mass can be rather straight. In a kyphosis, I would have maybe a large distance, so my center of mass needs to be stabilized even more because it has more distance to move to. On the other hand, the double S is a shock absorber. So we talk about dynamics again. So whenever I take a step, my ground reaction force will just jump back at me and will move through my joints and will be held, withstand with my muscles, just like that. So if I'm weighing 50 kilos, it's just 50 kilos of ground reaction force pointing back at me. If I'm walking with my 90 kilos, then it's 90 kilos. If you have an obese patient that has, let's say, 120 kilos, then it's 120 kilos that the patient needs to absorb in order to keep one primary goal active, which is the same in posture as in dynamics. Keep your head stable and the eyes oriented towards the horizon. It's always that same goal. And now, this week, we had a sunscreen just moved into the garden and I needed to carry a 20-kilo stone with me. So I'm weighing 90 kilos. So that stone was adding 25 kilos to me, so I was at 115 kilos overall, which I needed to move up the stairs. So basically that's the real scenario. So we have patients that do weigh 115 kilos. They need to carry around. For me this was a very high load. And it was really, so I was really glad when I took those 8 steps and I was able to put that stone down again. And, but that's basically what we're dealing with. And how the kilos that point back at me as a ground reaction force, these need to be absorbed. The more kilos shoot up, the more action I need to take, the more energy I need to exert in order to do so, and to keep that one straight goal, to keep my head stable. And whatever will happen, this will be what my head is doing. My head will be stable, no matter what. Our plumb line, that's the 0 line in the sagittal plane, is starting at C7. My pelvis is slightly posteriorly from it. So that would be the position of the pelvis. And you normally can always connect this to the lordosis apex of the lumbar spine, which is always right from the 0. So that would be 3 degrees of anterior tilt. So it's like a little tiny forward bending, which is exactly the neutral position that we normally would assume if a patient is standing there without any issues. So a healthy, pain-free patient should be able to achieve 3 degrees of sagittal imbalance to the anterior. So that is how we measure, and that will be the normative value. So he's standing quite regularly with 3 degrees of an anterior. Still, he has this strong kyphosis angle. So that means the weight that gets shifted backwards in the thoracic spine is rather extended. So you can see this, how he's standing here. He's standing rather neutrally if we just connect this point with that point. But in between, the entire mass of the thoracic spine is shifted backwards. So this is something that your muscle structures need to withstand and to hold. So your trunk flexors need to eccentrically control this backward motion and hold the weight of the trunk, which is sitting on top of the lumbar spine. And therefore we have a permanent muscular interaction, muscular activation at this level, which then comes with muscular imbalances, we talk about antagonistic reference between extensors and flexors, for example. That could be muscular weaknesses, a muscle that is permanently loaded, permanently under recruitment will shut down at a certain stage because it's not able to do so. So we need to move towards the bone in order to take over the workload of a muscle. And the same goes for the upper ending of that kyphotic apex, because if you have such a kyphotic curve, you end up rather horizontally at the upper end. That means in order to bring my eyes back to straight level, I need to extend my head in order to do so. That means I have a potential for the cervical structures to have a more pronounced neck extension, which, as we all know, cervical muscles are not the most strong muscles, so we are not talking about a muscle structure that can hold the entire day an increased load. So, but they are for mobility, they are for keeping 5 kilograms of the head stable. So, but if I'm standing like this, I will have more of a torque in that area, so I will have an increased force. So tomorrow I will talk about torques and impulse and more physics a bit, so then I will try to introduce you a bit to that topic. But basically, if you just think of the normal head posture, when I say the head is at 5 kilos, maybe 6, this position is already increasing the lever, therefore creating a workload onto the muscular demand onto the cervical structures, which is at 30 kilos. So that's the difference. So just by the positioning of the head. And this outgoing here is actually prone to bring a head forward position, because that's the alignment, it's just pointing forward. So the head, we can estimate it to be somewhere here, if not anything else is just uprighting. So then we have the cervical structures, which can go into that steep angle and pointing, or in the long run, we will skip the cervical muscles and move over to the thoracic spine, where we go for some rigidity, so that we have a stable bony anchor that is giving us a base for everything that needs to be held on top of it. So in office workers, for example, if you see somebody working on a less ergonomically equipped desk, for example, so getting into his 40s, maybe his 50s, so the eye is getting weaker, so then the head moves forward in order to see what's the content of the monitor, and sitting there the entire day, they will never be able to hold the head just by cervical extension over the entire day. So they will start getting rigid and unflexible in the upper thoracic spine in order to get a bony structure that takes over the additional load of the muscle activation. And if we talk like this and think like this, so that's a good outlook to the afternoon session, we will have actually, well, that's the principle of compensation. So if a muscle is too weak to withstand his original load, then other structures need to take over. So that could be another muscle, that could be the bone. So muscular compensation, we had this yesterday in the breakout. If I have an ACL injury, I need to somehow get back to a good eccentrical control of my knee extensors while I'm touching the ground and taking over the load on that leg. So whenever I'm taking a step forward, I will need my hip extensors as eccentrically oriented muscles that control the amount and the degree of knee flexion. So if I come with a knee injury and I have an impaired muscle activation, so maybe my vasti are not firing that much or not recruited that much, I will take everything that I can in order to have a stable position here. So then I would probably also use my rectus femoris part of the quad to withstand eccentrically into that knee flexion. So rectus femoris is a good contributor for knee extension in eccentric control, but it is also a hip flexor, isn't it? So it is attached to the ASIS. So therefore, we have a muscle structure that, if activated, is a good eccentrical control in the knee, but it is also increasing the flexion torque in the hip, thereby overloading the glutes, because they are the antagonistic muscle structure that need to withstand. So then you might have a good compensation on one hand, which costs you something else at the other. That's the basic principle of compensation on a muscular way. If you're not able to use the muscle structure, so you may use the bone instead. So if I'm not able to withstand here, I may just have a first contact and the load response just with an extended leg. So then I can simply go like this and have a past retract. That's the deviation that we see. So then I will walk, touch the ground, and snap back into the extension. Or I even hyperextend just during the swing already, so then I will just touch the ground like this. So that's bony compensation. So I would take my bone as a stable position, move away from the muscles. The muscles do not have to work anymore, so my bone can do that in the early years, but will wear down. So I will move into issues at the later stage. So that is compensation. I need energy anyway. If compensation takes place, I will always need more energy than in the original, and this energy needs to be provided. So that's the cost of energy, that is the cost of compensation, and this is leading to the symptoms that at a certain stage will not be able to be coped, and then you need to go to the doctor because your complaints are too high, and well, the threshold of any pain acceptance is surpassed. Still, we have a good quality of the data. So what would you see here? Is there something that is catching your eye? So, is there anything somebody wants to tell us? It's just about, so we can't go wrong, actually. So there's nothing that would be severely wrong if we just start diagnosing. So that's part of the deal. So everybody tries to find something, and you'd be surprised how often we find the same thing. We just find different words to describe the situation sometimes. But still, it's just about what is shouting out loudest. Define flat back, where would you find it? Upper part? Maybe also on the lower part, isn't it? So it's also rather straight here, so we have both parts. Okay? Very well? Good? Okay, so you have a better view on the table. I think then you can also retrieve the value for that. Yes? So sagittal imbalance at 11 degrees to the anterior. So the norm would be 3, so he's at 11. So 11 degrees of anterior tilt would be something where I can fairly well say that the head must be in a very frontal position. So think of the 30 kilos like this. So that's his head like this. So the level would be the same. Then we come to the flat back. That could be a good compensation mode for it. In order to not overuse the cervical extensors, we can start going to a bony rigidity, so thoracic spine flattening, maybe also lumbar spine flattening at a certain other angle, and then he has a good, well-equipped, stable, bony position at which everything that comes cranially can be connected to, and so we have a good holding point there. Very well, that's basically it. And now we are moving completely away from a kyphosis angle. So his kyphosis angle is 59 degrees. We will never see that flat part with 59 degrees of a kyphosis. It's not reflected by any kyphosis angle. His lordosis angle is at 43, so still on a bit of a high end, but, well, somewhere he must compensate, doesn't he? So then he stays like this. And then in order to not fall even more to the front, we can tilt a bit, and so we can move ourselves back again. So that's like, well, you say it, a duck's butt. So that's something like this, like that. So, but that's it. So now, of course, we need some context. That's the thing that we need on a patient in order to judge whether that is some deviation that we need to address or something we need to deal with in another way. If I tell you that this is a professional American football player weighing approximately 128 kilos and is positioned as a guard in the O-line. So he earns his money pounding his body into an opponent and blocking everything away that comes at his side, with a starting position somewhat like this, and then he just leaps forwards like that and crashing into it. So that's his main occupation. He earns a lot of money for that. Now this context could explain very well our sagittal imbalance, and maybe also that rigidity of the flat back that we see in the thoracic spine and in the lumbar spine, because he needs the bony stability during the collision. So else he would need to have so quick muscular recruitments during the contact, which needs to step in milliseconds in order to get that stable. So then he has a stable construct which he can throw in instantly without any reaction time. We will not talk about what this will look like when he's 50 or 55 years old. But right now, he's earning good money, well, giving his body away like this. But then we need to talk about the sense of compensation, about the sense of orientation in a postural way, because some of those deviations that we see are a result of maybe a senseful compensation, which, if not present, would lead to a complete loss of that function. Now, as for the compensation and the sense of compensation, there's a good example of that. So if you think into neuropediatrics, so you have maybe a CP patient, and they are walking somewhat like this. No? So that's so in a plantar flex foot, a bit into the forward lean, and this is how they walk. So an unexperienced clinician would tell about a plantar flexor contraction because he's only walking on a forefoot. Now we need to reduce the plantar flexion contraction, of course, don't we? So it needs to get a lower tonus. So the muscle needs to relax in order to get the rear foot back to the ground again. But what will happen if we do that? So, and how could we do that? So then, in a regular classical way, we will have a Botox injection and just relax the muscle by chemicals. Then, our rear foot just goes down to the floor. But the result of it, that patient will not be able to walk anymore because his only compensation mode that enables the patient to move forward is just taken away. So whenever we see a deviation, we always need to think about why is that deviation there? Is there a reason for it? Maybe the patient needs that very deviation in order to get a proper function anyhow. So it's not every deviation that we need to take away. It's just to create an understanding on, oh, I'm sorry. That's basically what I can only tell you about the compensation itself. So try to understand why the compensation is there, why it is happening. Maybe there's some idea of the body behind it, and this one we need to understand as well and take it into account.